All right. Hello, 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 everyone. Thank you so much for joining us on another beautiful day of coffee and CEUs from the TBA-SIG. We have a pretty awesome presentation coming up today, so I hope y'all are as excited as I am. As usual, let me go through some housekeeping items really quickly just to start us off. This event is being recorded, and it's going to be uploaded into our DBA page after the event. If you're here for CEUs, there's going to be a Google form where you sign in and out, and the sign in has been sent out in the Zoom chat, but I will send it again after my little spiel. And you got to sign in within 5 minutes from the end of this spiel to be eligible for your CEUs. And the same process is going to happen at the end of the presentation. A sign up form is going to be sent out. Just make sure to sign out within 5 minutes of the presentation ending. And today's event is going to count for one BACB Ethics Learning CE. And we are going to be monitoring attendance throughout the presentation. So if you just have any connection issues or anything like that, just shoot us an email, let us know. We are at disseminateaba@gmail.com. And during the presentation, we would love it if you could keep your cameras on. It's always a great experience for the presenter to see everyone's faces, but of course, there's no pressure at all to do so. And if you have any questions, please send them in the chat. We're going to be really happy to answer any and all questions that you may have. And lastly, if you want some cool swag while supporting our dissemination grant, swing by our Cafe Press store and you can pick up a cool mug or a baseball tee like so for your future coffee and CEU events. And now, finally, I get to do the fun part of introducing our highly esteemed speaker today, Dr. Gabi Morgan. Dr. Morgan, they are all yours.
Thank you. Thank you so much. I am very excited to have this opportunity to talk about this topic with you all. So the title is Viewing Trauma ACEs Through a Behavior Analytic Lens. And this is a really big topic. There's a lot of components. This is only meant to be a brief introduction, and I encourage anyone who has clients in their caseload with known or suspected trauma history to seek further training on the topic. And I'm going to give you some resources at the end to help you in gaining further training as is directed by our science and by our ethical code. And I'll be referring to that various times like throughout the presentation. But first of all, about me and kind of how I got involved with this. So, sorry, I'm trying to get comfortable. So, probably like many of you, I've been working a long time with a lot of individuals with different diagnosed disabilities, developmental disabilities, all different types of various behaviors and diagnoses. And I was working in the private sector, so a lot of my families were pretty motivated to have me, and have our services. But then, as I moved into insurance-based services and school services, I started to encounter more and more individuals who were engaging in challenging behavior, and some of them had diagnoses I was familiar with. Some of them had autism diagnoses, some of them did not, some of them had other diagnoses, but very few of them had a diagnosis that involved traumatic experiences or events. But I started to see that a lot of their behavior was actually shaped by challenging experiences, challenging events. And specifically, one experience that really stood with me was I was working with a family. They were a foster family, and total confidentiality here, of course. I won't go into details, but the one of the children had an autism diagnosis, but it was clear that was not what was going on. His behavior was very specific to certain times and places and setting events, but not in others. So it wasn't a pervasive developmental disability at all. And he was engaging in tantrum behavior around different settings and circumstances. And he also was doing a lot of parentified behavior. He was sort of taking care of the siblings. And at one point, the foster mother took me aside and she just said, he needs something. I don't know what it is, but he needs something. And she had this huge team of people who were there to try to help her, but for somehow it wasn't helping what was going on with him. So that sort of set me into this idea that I wanted to get more educated about these topics, and that my background in developmental disability and changing a lot of behaviors around developmental disability had not necessarily given me this, this training. So I just set out to find out as much as I could, and that was quite a few years ago, 6 or 7 years ago now. And so here I am, still learning, and I hope you all are. So what I'd like to do first is, that's a little bit about me and where I came from and how I got into this. So I want to find out a little more about you guys. So I'm going to set this poll. And the first question in my poll is, do you work with individuals with ASD, intellectual disability, or developmental disability? And there's, once again, with this is going to be a brief poll. There's no right or wrong answers here. So the answer is either yes or no. And I'm looking at the responses, getting close to almost everybody. Thank you so much for your participation in this. Love participation. And a few more. All right, here I go. I'm going to end the polling. Ready? Here we go. So that is 100% of you. Here, I'm going to share results there. Share results. So 100% of you work with individuals with ASD, intellectual disability, or developmental disability. So, second question. Do you screen your clients and families for traumatic experiences when you begin working with them? You know, is this something that you do as part of your work, either required by an agency or if you work privately? And here we go. A few more, waiting for a few more people. There's no right or wrong answers here, by the way. This is just what happens. That's what data is about, right? Data is about what happens, not right or wrong answers. What we see. All right. And even if you don't know the answer to this, by the way, if you're not the one, just go ahead and say no. Because if you don't know the answers to whether your agency screens people, go ahead and answer no. All right. So I'm going to end polling in 5, 4, 3, 2, and 1. End that polling there. Share results. So most of you said no, and which is fine. And that's actually just, that is part of this whole presentation. So if you do you use a specialized screening tool for that? If you do indeed screen. If you don't screen, just say no to this. Look at the chat, make sure. For some reason it's not allowing you to submit. Okay. Yeah, answer in the chat if it won't allow you to submit. All right. So here we go. Do you use a specialized screening tool? If not, just say, if you don't use the tool at all, if you don't screen, just say no. Go ahead and mute that. Okay. All right. Thanks, you guys, for your, I really love audience participation. So let's see. And I'm going to go 5. Now I'm going to give people a little bit more time. As I said, if you do not screen, just go ahead and say no. And I'm going to count down 5, 4, 3, 2, 1. Bam. And I'm going to share those results. And so once again, a lot of you do not use a specialized screening tool for that, and a lot of people don't screen for traumatic events, and that's fine. So if you do you use the information from the screening tool to inform your interventions? Once again, if you don't use the tool, just say no. That's the easiest way to make the to actually make the survey make sense. Just say yes or no. And once again, no right or wrong answers here. It is what it is. It is data. What do? We collect data. That's what we do. We're behavior analysts. All right. So this is not any kind of a scientific screening, as we do not have a sample that would represent that in any way. However, I think it's good information. So I'm going to end the polling and share the results. And there it is. So this is great information to know and think about. And I want you guys to think about these polls and these answers to these polls as we go through the presentation. And I want to find out, I mean, at the end, I kind of want to know, like, has anything of what I said, does it make you want to change the way that you do that, or change some of your behavior going down the road? I'm going to, somebody need to mute. Okay, so what are we talking about when we talk about trauma? Here is one of many, 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 many definitions of trauma. So this one is from SAMHSA, which is the Substance Abuse and Mental Health Services Administration. They have a lot of information on their website. A lot of it's mentalistic, not all of it's behavior analytic, but doesn't mean it's not useful. We can get information from it. So individual trauma results from an event, a series of events, or set of circumstances that is experienced by an individual as physically or emotionally harmful or life-threatening, and has lasting adverse effects on the individual's functioning and mental, physical, social, emotional, or spiritual well-being. That's a lot. That's a lot of things. And the definition has to be big enough to encounter. This is a big topic. So what I have here is, I didn't want to have this in my entire presentation, be pictures of very sad children. So I tried to avoid that, but the first one, there's a sad child. I'm sorry about that. But this is the truth. This is one definition of trauma, and I think it's important to think about that and keep that in your mind. Now, one of the many schools and classrooms adopt what are known as trauma-informed, trauma-aware, or trauma-sensitive approaches and curriculum, and you may have encountered some of these in your work environments. A lot of schools do trauma-informed work, and so some of the principles for a trauma-informed approach are safety, trustworthiness and transparency, peer support, collaboration and mutuality, empowerment, voice and choice, and awareness of cultural, historical, and gender issues. One of the big overall emphasis is in what happened to you rather than what's wrong with you. So one thing that I look at as a behavior analyst when I see this is that operationalizing some of these is pretty hard. Using these to actually guide what happens day to day and moment to moment in a classroom or in a setting or in a session is very hard, because they're sort of big picture concepts. And I actually found the same thing when I talked to teachers. Teachers had a very hard time. They would go to these trainings and they'd say, oh, use trauma-informed approaches. Well, okay, what does that mean? Like, what does that look like in the moment with this individual that I'm in front of right now? And that's one of the challenges, I think, in terms of us looking at trauma-informed approaches. But so behavior analysts also intersect with trauma-informed approaches in a lot of ways. So we emphasize the role of the environment in shaping behavior. We look at the various environmental contexts and circumstances where the response patterns were learned. We're supposed to focus on positive reinforcement as opposed to punishment procedures. We're supposed to program antecedent interventions and choice whenever possible. We look at the history of reinforcement and punishment in the individual's life. And we pay special attention to the function of behaviors that serve the individual to get their needs met. And another way we may be helpful is in determining when an intervention suggested by others might be inadvertently reinforcing challenging behavior or is in some way shaping other maladaptive behavior. So overall, because we are concerned with how environmental stimuli shape the behavior of individuals, so many aspects and ideas behind trauma-informed care actually complement our behavior analytic worldview. And I think that's really important to remember, that we can actually take some of these concepts, these big picture concepts in trauma-informed care, and we can translate them into actual approaches that are how we work with our clients. But here's a big question. Do behavior analysts treat trauma? The answer should be resounding no, we do not treat trauma. We address behavioral excesses and deficits by adhering to the 7 dimensions of behavior analysis, which, as we all know, I prefer the BACB acronym. People have their favorites. So behavioral, applied, technological, conceptually systematic, analytic, generality, and effective. We approach behavior, and sometimes it's private events. I'm not saying we don't address private events, but in general, we address mostly overt behavior. If you're an ACT person, maybe you are, then you might have a little more aptitude in addressing private events. But in general, this is how we approach things. So we don't treat trauma. Trauma is not a behavior any more than autism or depression are behaviors. They are concepts that encompass behavioral classes or response classes, and in some cases, the circumstances that make up those response classes. So, but what do we know? Some individuals who have experienced traumatic events are more likely to engage in behavior shaped by those events and that was functional or maybe even life-saving at the time. So these behaviors now might be unsafe, inappropriate, or maladaptive in other circumstances. So in trauma is suspected, multidisciplinary collaboration is preferable. So I put scope of competence with a big old exclamation point, because we are always supposed to be practicing within our scope of competence and seek training to expand our scope of competence. But we generally need to stay within it in some way. But that doesn't mean we don't have a place on the team. We do. So I'm going to stop there for a second. Does anybody have any questions or comments at this time? You can either chat it or you can unmute and ask it if you want. Okay. Awesome. Okay. I wanted to check in, and I will check in periodically, but please feel free to chat whenever you want. All right. So we don't treat trauma. However, here are a few of the behaviors that may be exhibited by individuals who have experienced significant or chronic complex ACEs, complex adverse childhood experiences. We're not supposed to attribute behaviors to diagnoses, but to environmental variables. So here are some of the behaviors: aggression against others or self, destruction of property, poor or non-existent impulse control, sleep issues, difficulty following rules, challenges in communicating wants and needs, impaired social interactions with family, friends, and teachers, lack of attention, difficulty focusing, and impaired task completion. And these are from Cook et al. 2005 and Vanderkolk 2017, and many other articles as well. And this is not an exhaustive list. This is a small list of the things you might see. But just on first looking at these, who has been called upon to address any or all of behaviors that look like this? Chat it out. Chat yes if you have. Yep. These are all behaviors that we have been, that we generally, you raised your hand. I love that. I love people raise their hand. That's so cool. Yes, these are all behaviors that we are generally called in to address at some point or another. And strangely enough, we're not supposed to attribute them to behavioral diagnoses, but to environmental variables, right? But how often do we actually do this? You know, do we look beyond the immediate circumstances that we see in front of us? The immediate functions, the immediate antecedents and consequences. You know, how often do we look at how the behaviors were actually shaped in the first place? We're not supposed to look at something like, say, autism or developmental disability as a cause for a behavior, right? That goes against our worldview. But when you are assigned to a case and the insurance says the reason you're assigned to the case is because the individual has X disability or X diagnosis, that becomes almost by default the reason that you're addressing these behaviors, right? That these behaviors came from that, but that's not our worldview. These behaviors were shaped in some way. Now, not everybody who engages in these behavior has experienced traumatic events. It's not what I'm saying. Saying that if you have clients exhibiting some or all some of these behaviors, it might be a good idea to screen and ask questions, look more closely, because that is what we are there to do. And we need to look at the environmental variables. So here's how we're going to do this. We're going to have a case study about a little guy named Stephen who is totally hypothetical. He is based on 4, 5, 6, 10 individuals I've known over the years. However, his case is not unique in any way. I've seen individuals very similar to him in many, many ways. So along the way of reviewing sort of his situation, we're going to look at these points. We're going to talk about trauma and ACEs. We're going to look at the ACE study. We're going to talk about behavioral conceptualizations of trauma and ACEs. And we're going to talk about some potentially contraindicated interventions when certain traumatic experiences have been had by the individual and why. And then we're going to talk about collaborating with a multidisciplinary team, and then I will share some resources with you. So here he is. Let's meet Stephen. He is, that's a great question, Glendon. Do an event relates to system. You know, that's a great question. And I'm not sure that I can answer it. I think that is a great question. But here's the problem. So I'm going to actually focus on individuals who don't have the ability to even express that that's a problem, that they can't. You know, a lot of our clients with severe disability can't report. They can't tell you if they're uncomfortable with the situation, if they feel that they have to keep reliving a traumatic event. They can't tell you. They lack the communication. And if that's the case, then it's our responsibility to help in whatever way we can to actually make sure we're not re-traumatizing the individual. We're not exposing them to further situations that are traumatizing. And that's, I think, an issue that I'm going to get into today. But the question is definitely a bigger question. At the end, let's definitely unmute at the end, and we can chat and see if we can get through it a little bit. Okay, is that good? I can see you, so I'm actually asking you to your face. Like, is that okay? Thumbs up. Okay, thank you. Appreciate it. So this is Stephen. He's hypothetical. This is a stock image from some photo thing, but he resonated with me. He looks upset about things. So Stephen is a 10-year-old boy. He's non-vocal with his diagnosis of autism spectrum disorder. He has no other diagnoses. There's nothing else there's no other diagnosis that he has been given. He uses an AAC device to communicate his basic wants and needs when prompted. And he is new to and attends a public school in a self-contained classroom. So this is Stephen. He's similar to many kids I've met, many kids maybe you have met. Those are some pretty, typical characteristics of individuals maybe on our caseloads. So what else do we know about Stephen? He engages in, he's at school anyway, he engages in aggression, tantrum behavior, elopement, and food stealing. He's new to the school district. So the BCBA, who is assigned to multiple schools in the school district, has a large caseload, discussed his behavior with the teachers and observed him in the classroom over a 2-week period. She was told that his records had not arrived and his parents did not respond to any requests for information. So in her observations and discussions with the teachers, she found his aggression and tantrums were primarily maintained by attention, the elopement was by escape, and the food stealing was by access to tangibles, food in this case. All right, got to address the behaviors, right? Okay. So our hypothetical BCBA implemented an intervention package. She used positive reinforcement, she thought about positive reinforcement. She instructed the teacher to deliver attention. We was engaged in appropriately following classroom routines and following directions. Teachers had many challenging students in the classroom, so she said that she would do her best to do this. She tried to pay attention to him when he was following directions and doing the right thing. Then the BCBA modeled how to remove attention from the tantrum and aggressive behaviors, and as well as escape extinction for the elopement procedures. So don't remove the demands and don't, whole thing. So she's modeling some extinction procedures. And she noted that he seemed to be motivated by food, right? He's food stealing. He's motivated by food. It's a reinforcer, potentially. So she trained the paraprofessional assigned to the whole class to deliver small candies to him using a DRO procedure about every 10 minutes when he didn't engage in target behaviors. The paraprofessional was, she was on board as much as she could be, but she wasn't available during lunch, recess, and specials. So this is an intervention package. Okay, sure. I've seen similar ones in schools, maybe some of the components, maybe some are not, but she's trying to address the behaviors, right? Now, I'm not saying there's anything wrong with this treatment package. Okay, she observed him. She figured out functions of behavior as much as she could. She didn't have access to the records. Okay, so then what happened? On Wednesday in the cafeteria, Stephen pushed another child and stole food from his plate. A male staff member loudly reprimanded Stephen, and Stephen ran away from the area. Other staff got involved and chased him, resulting in multiple adults restraining him. So the principal removed Stephen to a seclusion room and called his parents to come pick him up. After 2 hours, the parents arrived to get Stephen from the seclusion room. This portion, various parts of this are based on actual situations I've seen for individuals that I know have a known trauma background. There was a boy I know who was 10, didn't share a lot of characteristics with him otherwise, but he had trauma background. And yes, he was actually restrained against a wall by multiple adults when he was engaging in elopement behavior. And this was a vocal child. This child was actually saying, "Let me go," and he's being restrained by adults. So these are well-meaning people. I'm not saying they're not. However, there are better ways to do this. Now let's see what else. There's one piece we don't know about Stephen, which is everything, actually. So Stephen's 10-year-old boy, non-vocal, has a diagnosis of ASD. He's been physically abused in the past by his father, who was incarcerated for a brief period. His mother has a history of drug addiction, which resulted in recurrent periods of neglect, including inconsistent access to food and care when he was younger. Sometimes his mother would leave him at his grandmother's, where he would have a more consistent schedule for a few days or months. The grandmother said that she could no longer handle him now that he was older. So family services moved him to foster care, where he's currently living in a safe home. The foster family was well-meaning, but has never had a foster child without communication or self-help skills, and they're feeling really overwhelmed. So Family Services has recently begun allowing weekly supervised visits with his biological parents on Wednesdays after school. And then so on Wednesday in the cafeteria, Stephen pushed another child, stole food from his plate. A male staff member loudly reprimanded him, and he ran away from the area. Other staff got involved and chased him, resulting in multiple adults restraining him. Principal removed Stephen to a seclusion room, called his parents to come pick him up. After 2 hours, the parents arrived to get Stephen from the seclusion room. All right. Given the additional information, should the BCBA have done anything differently if she knew this information? I am going to say yes, personally. There are things that the BCA could have done differently. Now, she didn't have access to the records, get that. However, putting in certain interventions before you know all the information might not be helpful. So I'm going to give a little list here of, this is according to Milkolu 2020, there are some interventions that should be avoided following specific traumatic experiences. These aren't individualized or absolute. A risk-benefit analysis should be done in every case. So you should know what it is and what the risks are for everything you put in place. And yes, extinction procedures have risks. But so do reinforcement procedures. You should know as much information as you can. For instance, and these are just a few examples. So if the experience is chronic food insecurity or food-related neglect, you should avoid, at least at the beginning, the use of edible reinforcers. So in our situation with Stephen, the paraprofessional was told to deliver edible reinforcers in the, and it was actually a differential reinforcement of other behaviors, a DRO. So it was just every 10 minutes, if he didn't engage in these challenging behaviors, he was going to get candy. So the risk is, at least one of the risks is, it may evoke problem behavior that has led to past access to food, and the deprivation of it, if he doesn't get that candy or that edible reinforcer, there could be a similarity to conditions to past neglectful conditions. So that could all lead to evoking of either similar problem behavior or other problem behavior. You could actually get some generalized responding, all kinds of different behaviors new challenging behavior could emerge. And as an alternative, maybe using consistent unconditional access to food that appears at certain times, and this is the food, and that's how it comes, and it's healthy. And other potential reinforcers should be identified other than edibles. Another experience, past neglect involving lack of attention or contact. You might want to not use planned ignoring or extinction of attention related behavior. And in our situation, that's exactly what happened. So if we go back to our page of the package intervention, which I believe was this page, the BCBA modeled how to remove attention from the tantrum and aggression behaviors. And so they were putting them on extinction. And instead of that, so the removal of the attention from the behavior that was learned under similar circumstances might worsen the behavior, the attention maintained behavior, and could also compromise building any relationships with providers. So this teacher, he's new to the classroom. Maybe you're a new therapist with the student. So you're suddenly removing attention, and that can actually mirror some of the same circumstances under which this problem behavior was learned in the first place. So instead, think about enriched environments, non-contingent attention, and maybe even conditioning your providers as neutral, as first neutral and then as positive stimuli, and focus on teaching alternative behaviors to gain attention while you do that. So instead of just removing attention, deliver it on a rich, maybe neutral basis to start, and then start delivering more praise and positive attention. And then we have, if the individual has experienced physical abuse or revolving or inconsistent caregivers. I put these together because they were presented together where I found this information, but the physical abuse part is pretty important. So you want to limit the physical contact or restraint. So don't go, touching individuals who you don't know their background. You don't know what they've been through. And if you suspect that there's a background, don't just go putting your hands on them all the time. It's even in a, if you see it as a reinforcing or a pleasant way, it may not be seen that way. It may not have been experienced as reinforcing. It may lead to, so physical contact restraint may reflect the conditions of the abuse. It may actually evoke behavior that is challenging behavior. You want to pair safe adults with non-contingent neutral attention. And I want to put this one separately. So revolving and consistent caregivers, be really careful about contingent praise or access to attention for compliance, because what that can lead to is over-compliance in unsafe situations, especially if the individual is still in the situation, is not in a safe place. It also you're not teaching them to actually discriminate between safe and unsafe situations, like where you should comply and where you shouldn't. That can lead to a lack of self-advocacy skills. So instead, you want to teach self-advocacy, choice, and safe negation, saying no in some situations. I've met individuals who are in extremely safe situations and who are safe and who have loving families, but I was a little bit disconcerted by the amount of compliance that they showed. They were too compliant. I met an 8-year-old girl lovely little girl, she was wonderful, but nobody had ever taught her choice making. Nobody had taught her that it was okay to say no to adults. And I remember looking at the parent and I said, I don't want to freak you out or anything, but I think this needs to be taught to her. She needs some assertiveness. So whenever I hear about compliance as a goal, I have to admit it gets me a little bit nervous. Always question that as a goal. Like, do we want compliant, or do we want follows directions when it's appropriate? I think that's really an important choice. So these are things to consider. And I'm not saying that these interventions should never be used. What I'm saying is that the risks versus the benefits should be analyzed. If you have an individual who's engaging in behavior that is so unsafe that that they're going to injure themselves or somebody else, you may need to put in an intervention that's risky, that has some risks attached to it to protect them and others. But you should always be willing to look at some alternatives and try those first, and always do a risk-benefit analysis. I'm going to talk a little bit more about resources at the end, but Cusp Emergence University, which is Camille Kolu's site, has a really good part of her training is on risk-benefit analysis. And I think it's a really, really useful training for all of us to sort of have in our pockets. All right. So ACEs. What are ACEs? ACEs stands for, we got a question. I have to go into chat. Okay, thank you for putting that in there. Yes, cuspemergenceuniversity.com. She has webinars, and also just cuspemergence.com is a site, like a blog site that she has with a lot of blog postings about these topics. So ACEs stands for the Adverse Childhood Experiences Study. The term came from the ACEs study, which was a longitudinal study conducted between 1995 to 1997 with over 17,000 participants. And they answered questions about the prevalence of traumatic experiences in their childhood. So this was these were adults via self-report questionnaire. There were three main categories. As you can see, there's household challenges, abuse, and neglect. And these were the categories they had at the beginning. Abuse included emotional abuse, physical abuse, and sexual abuse. And household challenges included violent treatment of a family member, substance abuse in the household, mental illness in the household, parental separation or divorce, and having an incarcerated family member. And neglect included emotional and physical neglect. So data has continued to be collected from the same participants to the present day, and it's also been used in hundreds of research articles across multiple disciplines. And people are still conducting new studies using the questionnaire. It's been expanded to 10 items that's still in use today, but they've added a few. But the data stayed fairly consistent over time on what people actually experience. So Stephen, in our example, had an ACE score of at least 5, maybe 6. This puts him in the category of complex trauma. And as you can see over here, people with 6+ ACEs can have been found by the study to die up to 20 years earlier than individuals with lower ACE scores, for those who have none. So 1/8 of the population have more than 4 ACEs, and with 4 or more ACEs, there are all kinds of increased risks. Now, what is one problem you can see with the ACEs study in relation to our clients? Like, what's one issue? Maybe you want to chat what one issue potentially is with this, or unmute, either way. What do you think? It is a self-report study. So all of these people, all of this information came from people who were able to report on their experiences. So up until recently, we have not really known the prevalence of ACEs, adverse childhood experiences, in the lives of individuals with disability. So I'm going to show you some of the data that I found, because recently, especially in the last 3 years, but starting around 2009, people started to say, what is this? Like, what's going on with individuals with disabilities this way? So people with an intellectual disability are at least 3 times more likely to experience adverse life events, abuse, and trauma in childhood compared with others in the general population. Okay, that's right there, not good. And this study came out in 2019, McDonald et al. They found individuals with ASD plus intellectual disability and intellectual disability experienced overall higher reported and substantiated rates of maltreatment compared to the control groups who were without diagnosed disabilities. But however, the ASD only and the ASD plus intellectual disability groups had higher report rates. Only the intellectual disability group was more likely to have substantiation for the reported maltreatment. So without substantiation and without the ability to prosecute, without the ability to say what happened, nothing happens. Nothing is changed. Nothing helps the individual, right? So this is a problem. And one of the things they brought up in this study that was very interesting is that if an individual has severe challenging behavior or has a lot of deficits as far as communication, as far as appropriate behavior, sometimes the empathy of the workers who came out to investigate the case was with the parents, was with the family, so there was even less chance that the individual would actually get help for their situation. All right. A few more things to keep in mind when you come across your clients, that kids don't often get diagnoses based on their trauma, on their traumatic experiences. So in a sample of 63 children who each experienced 3 or more traumatic events, including physical abuse, only 7 had been given a PTSD diagnosis, whereas 21 received an ADHD diagnosis. So this doesn't just come along with your clients when you're called on ASD case, to be a behavioral science ASD case. If you work with individuals with ADHD, there's a higher rate. Many of the trauma-related disorders listed in the DSM-5 require the individual be able to describe thoughts, feelings, and experiences. Individuals with communication delays, autism, and other disabilities may not be able to report abuse and/or may exhibit behavior attributed to the diagnosed disability rather than the abuse. And individuals with disabilities are frequently taught to be compliant to both adults and peers, and that to allow physical prompting, and they may be reliant on others for needed care. All of these things lead to a higher prevalence of abuse for these individuals. So we are mandatory reporters. Never forget that. And it might save someone's life for you to be a mandatory reporter. If you see something, say something. So this data shows and mirrors actually what we saw in that very first poll that we did. Majority of individuals who are BCBAs work with autism spectrum disorder at 73.6%, and then 2.95% work with individuals with intellectual and developmental disabilities. Now look at here, this I find interesting. Only 0.24% work in child welfare of BCBAs, and only 0.08% work in corrections and delinquency. I think we need more of a presence in here. We need to learn more, and these need to intersect more. So we need to be somehow disseminating what we bring to the table and also being able to get in there and help these other individuals. We need to learn more. So what does it mean to view trauma through a behavioral analytic lens? Individuals who have learned behaviors under environmental circumstances that are chaotic at best or abusive at worst may not have learned societally appropriate ways of getting attention or engaging with others. So in approaching ACEs from a behavioral standpoint, we can view behavior shaped by adverse childhood events as subject to the same lawfulness as any other behavior. And this may help us shape the most effective yet humane treatments and inform environments that avoid further aversive circumstances. So I cannot recommend this article enough. Prather and Golden, 2009, a behavioral perspective of childhood trauma and attachment issues toward alternative treatment approaches for children with a history of abuse. This article, I read it, it changed my life. They talk about respondent conditioning, motivating operations, schedules of reinforcement, and other principles of behavior. So I'm just going to briefly mention some of these in terms of Stephen's experiences. So we have our respondent conditioning, which has been kind of downplayed a little bit recently by the task list, which I'm not totally in favor of. It's characterized by the conditioning of a neutral stimulus to become a conditioned stimulus, leading to a conditioned response, right? So respondent behavior is the response component of a reflex. So that's behavior that's elicited or induced by antecedent stimuli. Respondent conditioning, stimulus-stimulus pairing procedures in which a neutral stimulus is presented at the same time with an unconditioned stimulus that elicits a conditioned response. So little Albert, white bunny, no fear response. Loud noise, fear response. Loud noise plus bunny, fear response. And then what happened later? Bunny, fear response. Poor little Albert. So let's think about Stephen. His father maybe spoke in a loud voice. It could have been followed by abuse. And he may have experienced this sort of increased heart rate, shortness of breath. And then he might have had a fight, flight, or freeze response, the autonomic nervous system. So these are paired together, and in the presence of this loud voice that was paired with maybe this, with abuse, running maybe kept him very safe, right? So that could be the conditioned response. Now think about it in terms of other stimuli that are similar to that loud voice, maybe a loud cafeteria, maybe somebody even yelling, maybe somebody reprimanding another child, another person. So now we have sort of this conditioning, we have conditioned motivating operations, basically. We have conditioned responses and conditioned stimuli. So it could be almost anything, but you need to find out what those are and don't underestimate the role of respondent conditioning in those circumstances. Then we have the motivating operations, which is a situation that increases or decreases the value of specific reinforcers and increases or decreases the momentary likelihood of all behavior that has resulted in access to the reinforcer. So let's look at Stephen once again. So if we're looking at the role of the motivating operations in his behavior. So we have value altering and behavior altering effects. For instance, for Stephen, the presence of a reprimanding adult may increase the value of escape as a reinforcer and momentarily increases the likelihood of all behavior that has resulted in escape in the past. This could be running, this could be hitting, this could be tantruming, whatever it was, it increases momentarily that behavior. Feeling hunger increases the effectiveness of food as a reinforcer and has an evocative effect on behavior that's resulted in food in the past. Stealing food, tantruming, whatever it was, whatever got him food in the past. So it's really important to understand how these patterns can be shaped. And then honestly, you have to, that's a great question, Dana. She asked, how do you gather information about potential environmental triggers of reprimanding adult when the parent is likely the cause? Honestly, if the individual is still in the environment, part of what you have to do is just review all the records you can and try to actually err on the side of interventions that don't have the aversive effect. And maybe you might even need to, again, if you're the mandatory reporter, try to help the situation as much as you can. It matters. Are we in the home? Are we in the school? Where do we encounter the individual? I think gathering information and then parent training, honestly, like that's really one of the things that I think can be most helpful and one of the places where I think we can be the most helpful. And I think it's underestimated how parent training, shoot, I'm running out of time. Okay. I was going to point out the fact that when we look at this, parent and family training, 0.46%. We need more. We need to be more involved. We can teach parents to be better. We can teach them to increase positive reinforcement. We can do all these things. We have the science, behavioral science, magic. No, I'm just kidding. Science. Schedules of reinforcement and punishment. His reinforcement history may have included that food and attention were delivered intermittently. They were intermittently reinforced with access to food, the stealing tantrum behavior. We don't know what types of behavior may have been reinforced. Possibly few pro-social behaviors received reinforcement since his communicative repertoire was limited. So we don't know his history of reinforcement and punishment. We can pretty much see that some of behaviors that were reinforced by, say, escape, for instance, elopement, right? Elopement was reinforced negatively by escaping from the aversive situation. So that was life-saving in the past. We need to actually teach new behavioral repertoires in order to adjust for that. So how can we use our expertise to better serve individuals who have experienced traumatic events? We can seek training from within and outside of ABA and trauma ACEs. We can collaborate with other professionals, let them know that what we bring to the table, we bring a behavioral analytic perspective on the role of environmental variables, data collection procedures, but also listen and learn from them. Be willing to look beyond the immediate events, environment, and apparent functions of behavior. Integrate trauma screenings and assessments into your practice, and I'll show you some. Use a risk-benefit analysis to see if the intervention could be contraindicated and what to do instead. And be aware that the diagnoses do not always take trauma into account. And keep in mind, individuals with developmental disability, intellectual disability might be at increased risk for ACEs. Here are some resources. Here are some checklists. These are some trauma screenings, trauma symptom checklists for children. Has a lot of research. This one also has a lot of research. This is a newer one, but she's a BCBA-D, and I highly recommend checking out her work, safety checklist. She wanted to make something that was more useful for BCBAs. Here's some organizations and websites that have very good information. Some are behavior analytic like this one, and a lot of them are not. And here are some helpful articles that help to shape what my view on these things. Other than that, yes, I believe the slides will be available. And closing thoughts. Much more research is needed. Behavior analysts are in a key position to be important members of multidisciplinary teams. Our experience with individuals with communication and behavioral challenges means that we can make important contributions to improving the quality of life for individuals with disability who have trauma backgrounds. We need to screen for trauma, individualize our interventions according to our findings, and let's make sure that behavior analysts have a seat at the table for clients who engage in behavior shaped through exposure to traumatic experiences. And thank you. For further information, you can email me or whatever, and I'll stay on for questions.
Thank you so much, Dr. Morgan. This was fantastic. I think this is just like it's something that we all need as BCBAs, as people who work with populations that might not be able to communicate to us. Right? This is so needed.
Yeah, and we're good at that. That's actually what I wanted to express is we have experience with populations who can't communicate. And a lot of the clinicians who have the trauma background don't. And I've had that conversation I've had therapists call me and who shared a case with me, and they're like, I don't know what to do with this individual. She's mandated to come to my office for an hour a week, but he can't talk. I don't know what to do with him. And we've had talks that way. So I've been able to help the clinicians to actually approach these individuals in different ways. So we bring that to the table, but we have a lot to learn too.
Definitely. Yeah. Does anybody have any questions as we're wrapping up? You can come off mute as well if you'd like.
Wait, I'm seeing chats. I actually put the thing, so I can't see the chat now. I moved it. Let me see what it says. Okay, there it is. Oh, thank you, Valeria. I appreciate it. All right. So definitely check out the things I asked. Glendon, if you wanted to unmute, if you can, I saw maybe you're on a phone, but I'm not sure if you can. And ask that question again, because I wasn't totally sure that I got it right when I was reading it. I was reading it kind of fast.
Okay. Can you hear me?
Yep, I can hear you.
Okay. All right. I've been looking at incident which is known in British history or world history as the Hillsborough. This is where a couple of people, mainly children and women, they were in a stadium in the UK. I think it was located in Sheffield. And due to poor construction at the time, I think it was done the event occurred in 1989, where supporters from Liverpool Football Club and I think from Liverpool Football Club and they were housed in I think either the eastern or the western wing of the stadium at the time, and it collapsed. Basically, it was poor infrastructure, but the constant theme that is always rehashed every year is that they bring back as what we call a memorial experience, where they rehash or they relive the experience of what occurred in 1989. They go through what we call police reports, looking at evidence-based studies, looking at witness what we call witness, like actually looking at what took place, what happened, and like
Right.
what the impact it had on families and stuff. My thing, I think, based on my experience with the case, is that they should move on. 2 years is a long time to be looking at an event, and they had two inquests, looking at the police end. But normally what humans go through is a blame game, or what we call they blame one another, because no one expects and no one will take blame for an event or an aspect of trauma, whether either physical or emotional, because both aspects are there, and no one actually wants to deal with the real problem. It was just an accident that occurred based on poor infrastructure at the time. It was an environmental, let's say, environmental case scenario. My problem, I was looking at it, and I copied the dissemination group in it, is that how can you get these people to move on and see that 32 years is a long time? People may use the event as a way to gain money. People may use it as a way to gain sympathy. People may use it for other means, but I think 32 years is a very long time to be looking at an event and then rehashing it I don't mind people telling their stories, as I said, and building it for public morale or a case to build, rebuild on nationalism. But 32 years of looking at an incident that occurred in 1989, it has to come to an end at some point. Everyone is not going to be okay or au fait with that process of looking at the event. If you're going to look at it from different angles, because let's say someone survived the event of trauma, telling a story that occurred in 1989 is not going to have the same effect of somebody passing on its folklore, because it's a folklore now. No one that could have been there is going to have a factual piece of evidence as to what occurred. So if you're going to rehash that story, telling it from different, and everybody's going to add a different element to it, how do you get these people to say, well, you know what, it occurred in 1989. What's the best method to get them to accept? Because acceptance is the first case scenario of something that some trauma, either physical or emotional, and it will leave scarring and lifelong scarring at that, and it will have a ripple effect on employment agencies, anybody who's connected to it. The media will play out as a sympathy drive, and other people who are connected to will, let's say, use it for financial purposes. But my thing is to get the victims and the supporters and the main people who are impacted or impacted or affected by it to accept that 32 years is a very long time to deal with an aspect of trauma. And people, I don't want them to blame themselves repeatedly and pass on stories of regalia from generation to generation where there's no
I
factual base
totally
anything.
understand. I agree. And it's interesting like that you bring that up, because that actually, so if you look at the situation that the case study that we did here, the individual had the behavior on the Wednesday, right? Now, this is an individual who probably doesn't even have any comprehension of Wednesday as a day. He just doesn't know. However, there have been many, there's been a lot of documentation of individuals actually engaging in behaviors that are on or near certain powerful dates. And derived relations is, by the way, if we get in, I didn't even get into derived relations, but derived relations is a really interesting way to actually look at the how these dates, how these external stimuli acquire this kind of power. And so I think that, yeah, you're right. It's very hard to explain to people that, like, well, we should just get over it. We should move past it, and have people stop referring to it. And I can refer to here in the States, 9/11, very, it's a very traumatic situation experience for many people. People I know personally have an extreme reaction to that date. And I think some of it, I think that's sometimes where, if you are an individual who can access therapy, that might be one way to go. Like, you can't always convince the people who are in power to change what they do, but you can change your reaction to it. And I think if we can if we can, get enough people on board, maybe we can sort of change how that's presented. Like, maybe instead of it being like, oh, let's remember, maybe it's, hey, it's a day of where we actually help people. Like they've done with Martin Luther King Day, for instance. Like, that's turned into a day of let's educate ourselves. And so let's not just go. Does that make sense to you, Glendon? Does that help at all? I can't really help too much with it, but
if you're going to look at the element of follow-up, if you're going to look at the element of education where people learn differently, right? And then if you're going to look at learning theories in terms of putting things into practical experience. Everyone learns differently. Another problem I'm encountering is what we call people may have the concept, if you're going to look at education reform, using a universal concept of educating people. That is the first concept. You cannot educate everyone at the same level. Everyone has to be assessed. Everyone has to be individually assessed or group assessed. But my problem is, if you're going to look at a trauma, whether a traumatic event, you have to look at individual cases, and you have to have the ability to meet with the individuals and meet with the parties involved, and then go from there to form a baseline assessment as to find out what happened, and then go from there. So my problem is
how to
speak.
That's the problem.
So how do you speak with someone who carries, so how do you speak with someone who carries the educational element, and then let them know, well, I may not agree with your methods all the time, but as a psychologist who's attached, I think these are better methods of how to approach the person who's learning. So how would you go about that?
Yeah, Dr. Morgan, if it's okay. Glendon, I think these are amazing questions, but just for the sake of time, to respect Dr. Morgan's time,
no problem.
No. Glendon, if it's okay, her email address is right there, gmorgan@bapath.edu, and for everyone
I'll do my best. If anybody else has a specific question, quick one they'd like to ask, that's totally fine. Otherwise, thank you, Glendon. Appreciate it.
No problem.
All right. I think that we can go ahead and say goodbye. So thank you all for attending. I really appreciate it. And you all were fabulous.
All right. Thanks again, Dr. Morgan. Everyone,
have
a great weekend. Go save the world with behavior analysis.
Save the world, behavior analysis.
Bye, everyone.
Bye, everybody. All right.